Live.
Hello, everyone. My name is Hameed, and I'm an associate editor of Journal of Cardiac Surgery and Integrated Cardiothoracic Surgery resident at Yale. I would like to welcome everyone to our monthly live talk on Journal of Cardiac Surgery, where we discuss a key paper that has been published on the journal. We're joined today by Dr. Gianluca Torregrossa from University of Chicago, who is associate editor of Journal of Cardiac Surgery and a robotic cardiac surgeon. We also have Dr. John Ikonomidis, who's professor of cardiac surgery from University of North Carolina at Chapel Hill. And we're joined by Dr. Tohru Asai from Shiga University, Japan. He is the senior author of the paper we will be discussing today. Welcome, everyone. And we're also joined by our live viewers from the internet on YouTube, Twitter, and LinkedIn.
Welcome, everyone. And thank you a lot, John. Thank you a lot, Tohru, for being here. That's a great opportunity to discuss the paper. And thank you a lot, Irbaz, for the presentation. We wanted to go directly to a small presentation that Professor Tohru Asai has offered us. And we can see.
We also employ external introduction of selective cerebral perfusion cannulas only after we confirmed integrity of intima in the supra-aortic branches. With such safe cannulation, appropriate use of hypothermic circulatory arrest and relatively brief CPB, the total arch replacement becomes a fast recovering operation. This is a 75-year-old man with a distal arch aneurysm. Epi-aortic scanning was used to find the best site for arterial cannulation. The patient was cooled down to 25 Celsius of tympanic membrane temperature. Circulatory arrest was induced. When we opened the aorta, the ascending and transverse arch were found severely atherosclerotic, particularly at the orifice of supra-aortic branches. A sharp cut was made at the first and second arch branches using a number 11 bladed knife. SCP cannulas were introduced gently after confirming smooth intimal surface in the branches. 3 SCP were instituted. The diseased aorta was carefully separated from surrounding structure. You can recognize the atheromatous debris everywhere in the aortic lumen. Adherent lung was occasionally separated from the aneurysm, sacrificing aortic wall surface when necessary. The huge arch aneurysm was removed. The distal anastomosis was constructed with a 28 mm gel weave plexus prosthesis. 3O protein running suture was simply used, with Teflon felt reinforcement outside, making a large and balanced bites with about 8 graft crimps telescoped inside the distal aortic lumen. This is crucial to prevent leaks. Distal perfusion and rewarming were initiated following that anastomosis. Then, the proximal aortic anastomosis was constructed with outside felt using 4O protein at the sinotubular junction level in the same fashion. The left subclavian artery was constructed with fiber protein. Hemostasis was confirmed. During construction of the rest of supra-aortic branches, the temperature reached 35 Celsius and the heart started to eject. After all anastomosis were completed, CPB was terminated.
Perfect. Thank you so much for the video, Professor Asai. Thank you for being here. And tell us a little bit more about your experience that you have discussed in the paper that brought all of us here today, total arch in chronic kidney disease. What is your experience in your university? What do you do? And what is your strategy for surgery?
Thank you, Gianluca. First of all, it's a great pleasure to be invited here. And our practice, actually, I was trained in the United States in the cardiac fellow at the time. I've never seen total arch replacement. And I don't know, maybe it's a regional difference. In our country, Japan, we have a fair amount of thoracic aortic surgery, elective thoracic aortic surgery. Out of, I'd say, out of 200, maybe 30 cases of aortic arch elective cases per year for myself.
Mm-hmm.
So that may be a little different from that country. One of the reasons we have that many operations, we have so many CAT scan follow-up for the some other. They accidentally find mostly 80%, 75 to 80% is atheromatous aneurysm. I'd say degenerative aneurysm, not a chronic dissection. Mm-hmm. Chronic dissection, you can see in our paper, I think 15 to 20%. That may be different from the United States or Europe.
Sure.
But anyway, that's the total arch replacement has been most technically demanding, also time consuming. So we changed this, I think, order of anastomosis, also the strategy in terms of temperature management and selective cerebral perfusion, circulatory arrest. I think I should go step by step. So, Gianluca, you can ask.
I will ask Professor Ikonomidis. I will ask him. What is your strategy, Professor, and what do you think is after you read the paper? What is your strategy in chronic kidney disease patients that are generally kind of a sick patient population? And total arch surgery is always with circulatory arrest is always a lot of surgery for this type of patient. What are your insights? What is the vision from this part?
Well, I really like the video, Dr. Asai. I think you know, your approach to operations in the arch is really identical to mine. The idea being that you know, use of at least selective antegrade or complete antegrade perfusion of the head really allows you to decrease the amount of hypothermia. And if you time the steps of the operation appropriately, like you did, you can start rewarming. And you know, in my opinion, the reason patients get into trouble with arch surgery is because of the amount of time they're on bypass. And then when you finally come off bypass, you can't stop the bleeding. It's a mess. And so, you know, you put together an operation which really decreases the amount of time you're actually on pump. And you're operating while you're cooling, you're operating while you're warming. And I have a very similar approach with how I do it. And I find that I don't have problems with getting hemostasis. And I don't have problems with excessive volume use, problems with myocardial protection, and that sort of thing. So
what do you do?
I'm sorry?
How do you do it?
So my operation choice generally is a cannula or a graft sewn onto the innominate artery. And I will use that for selective antegrade cerebral perfusion. And so I use that, for example, for hemiarches. If I'm going to do a complete arch procedure, I may supplement that with a separate cannula in the carotid. And then my approach is very similar to Dr. Asai.
What temperature do you go, Professor Asai, Dr. Asai, what temperature do you go in? What is your general temperature?
As far as temperature management concerned, we monitor tympanic membrane temperature and so bladder, rectum. I mean, core temperature. But we, after induction of anesthesia, we put the ice helmet and simultaneous surface cooling together with the core cooling, and we see rapid drop of temperature of a tympanic membrane rather than rectum. So when tympanic membrane temperature reach somewhere around 25 degrees, rectal temperature or bladder temperature is usually still 30 degrees or 29 degrees. So separate temperature management we usually use. So I think the brain is most important. Of course, spinal cord is also important. However, I think 28 core temperature, somebody said, but what does it mean? We always ask. I think nasopharyngeal or tympanic temperature to be moderately low, which could be good enough. Mm-hmm. I don't have a good evidence, but from our 400 cases, we haven't had any, for example, spinal cord ischemia related paraparesis or paraplegia at all. We don't use frozen elephant trunk, which is the trend in Japan or some part of Europe, but that we cannot eliminate these spinal cord injuries. Maybe that would be next later. I think Gianluca may just talk about future of aortic surgery.
Yes,
but
correct. We wanted to imagine
most bad complication is the embolic event to the brain or spinal cord. So we just minimize the cardiopulmonary bypass related coagulopathy or systemic inflammatory reaction. As you read the article, as our impression, if we can limit a certain amount of time of cardiopulmonary bypass time, I think patients look better, recover quickly. You don't have any embolic event. It's just like open bypass. I don't know. That's just impression basis.
I completely agree.
Do you agree?
I completely agree. Yeah.
So somehow, even in this patient's population, at the end, going for a circulatory arrest is not the most complicated or
I'm sorry, Gianluca, I can't hear you well. Has some sort of noise coming. Can you just repeat?
Oh, we can't hear you.
Yeah.
Now I can hear you.
I can hear a lot of double sounds, so I'm trying to optimize the sound to increase the experience. I was saying, at the end, even in this patient population, that is a very complex patient population, the circulatory arrest time can be managed appropriately without major issues or without being too worried about going too cold. We were discussing about frozen elephant trunk and temperature, and I want to ask to both of you. First of all, let's say that you have on the shelf a frozen elephant trunk prosthesis. Would you use it? When do you use it in a patient like this? How that will change your operation? What type of indication frozen elephant trunk has or will have when you have it in your practice?
We do have frozen elephant trunk products in the shelf, but I used only twice. Which one patient already stented descending aorta, so we don't cause any occlusion of intercostal artery. That is safe.
Yeah.
Otherwise, I think it's very. This is the philosophy, Gianluca. If you have a 1% of paraplegia risk operation, which is easy operation, okay? The other, it may be a little bit more technically difficult, but you will not cause any paraplegia. I definitely take this.
Yeah. What do you think, Dr. Ikonomidis?
And I think the cause and the incidence and the mechanism of paraplegia have been discussed in many occasions, but I know even before the commercial product, there's a horrendous phenomenon for many cases in a previous facility in Japan. They have a handmade stent graft combined with conventional graft.
Yeah.
It's up to 15% of the paraplegia, and you need to realize this chronic patient is mostly asymptomatic prior to surgery. Now, all of a sudden after surgery, he cannot move at all. I had one patient commit suicide. I would not like to be a surgeon to making such kind of patient, even one patient out of 1,000. Period.
What is your experience, Dr. Ikonomidis? What do you think, and where do you see frozen elephant to be used?
The frozen elephant has utility in arch aneurysms where there's a substantial descending thoracic component, in my opinion. So, and also in chronic to some extent. I've attempted to place them. Oh, the sound went away. That's awesome. Can everybody hear me?
Yes, very well. Okay. Finally, we found it.
Maybe it's because two people muted. That might have been it. Maybe we should, when we're not speaking, maybe we should just all mute. That might be better. So anyway, I've tried to place on a couple of occasions, foolishly, I've tried to place a frozen elephant trunk in an acute dissection, and it's very frightening because the septum is extremely friable, and you just don't want it to tear. And so I must say I've honestly attempted it, but never been successful and sort of given it up. So it's really indicated, in my opinion, in chronic dissections and aneurysms where you anticipate that there's going to be distal intervention, and it just facilitates that intervention. Failing that, the next step would most likely be a debranching operation, where you would take the great vessels and take them off the ascending aorta, and that would create a landing zone somewhere in the arch for a stent graft.
Yeah,
that's kind of generally my approach to it.
When do you do this operation? I've done some of this operation with Dr. Gabe Diluozzo at Mount Sinai Hospital. He taught me how to do it completely off pump, and generally these were the sickest type of population.
Yeah.
When do you do this type of operation? And for the followers, we are talking about opening the sternum off pump, doing the free distal anastomosis of the free supravessel branches, or two from the front, and do the anastomosis still of pump with a side clamp on the ascending aorta, then complete the anastomosis of the subclavian. If you cannot transpose down into the arch, you can do a carotid to subclavian bypass, and then close the sternum and do the endovascular procedure of closing completely with an endoprosthesis the entire arch down into the descending thoracic aorta.
Sure.
When, Dr. Ikonomidis, when do you recommend this type of surgery to your patients?
Sure. I recommend it when formal operation is going to be hard. So, and you know it's going to be hard under a number of circumstances. Patients with a very large antero-posterior diameter, high body mass index, where you're going to be operating deep in a hole. Sometimes very difficult to do a full arch replacement, even with a branch graft. And also some patients, they have the aneurysm, the great vessels are in the midline or even a little bit to the right, and they're right in your face. They're right here, you know, they're right there. In other patients, they're over here. In those patients, I would be more likely to attempt a debranching of two vessels. Usually you can do the innominate and left common. And then, as you said, carotid subclavian bypass and an endovascular stent graft. So a lot of it has to, for me, a lot of it is the anatomical consideration of my perception of how easy the operation is going to be. You know, fortunately, we have such terrific imaging now that you can predict exactly what the operation is going to be like. You know how it's going to go before it even starts. Yeah. And so our preoperative planning is usually very accurate. And if I think preoperatively that it's going to be straightforward, it usually is. If I think it's not going to be easy, then I might go with the alternative approach, which might be a debranching off the ascending.
Sure. Dr. Asai, what is your instead alternative technique, or this is your technique and this is how you do it? Do you have
please? John summarized that's I think very good, very important point. These group of patients often have a lot of comorbidity of other difficult condition. I mean, out of aorta, for example, lung problem, also kidney, and I think extremely obese patient, probably much more you see in the United States rather than in Japan. And these patients, you have to select appropriate procedure depending on these conditions.
Sure.
So yes. Also, elderly patient, you may encounter, how to say, frailty yes. Type of things. Which, so you have to measure your procedure, end up with complete aortic repair with nursing home. That's not our goal.
Yeah.
So, which is important. But at the same token, I think from my point of view, most important thing is to avoid any embolic event, especially for the central nervous system. No matter how less invasive, a small incision or newly developed stent graft, you have some tiny tip of arteriovenous things go to the, for example, vertebral artery. I had a bad experience previously. I mean, which is, I think, a nightmare. So aortic surgery, I'm not certain what is minimally invasive. At John's point, it's very important. You need to measure how difficult it's going to be when you go into operation. So we do have a special fenestrated arch graft named Nayuta, which I think made in Japan. I think it's the 3 fenestration. But I think the biggest problem at this point of time in our world, we have a very fine CT scan with some 3D reconstruction, everything. However, we do not have measure how fragile each soft plaque, which is, I think it's, no matter how you do open operation or endovascular approach, we need to do something to prevent embolic event.
Sure.
The whole course of the treatment, which I think it's the most important things and tip. John, so I think it's more important. Yes, I think that's great to remodel the. I think downstream of aorta. You can avoid chronic, large, I'd say, thoracoabdominal, huge nightmare operation. If you can finish, which is great, but how we can make progress to eliminate.
The other point about the frozen elephant trunks is that early data on use of the elephant trunk from Lars Svensson at the Cleveland Clinic and others sort of suggests that you don't want to make it more than maybe 10 centimeters long, because the tendency is for the section of the aorta that is subtended by the elephant trunk, it will thrombose. And 4 centimeters of thrombosis is okay. You might take out an intercostal or 2, but more than that, you're putting yourself at risk for paraplegia. So that's another consideration with regards to using the device.
Mm-hmm. The point is, but John, you made this, contour, the shape of aortic arch is different from case to case. And some distal curvature, you are the expert, so you know that it's not same to the straight descending aorta. Bird's peak type of malattachment, or just a newly developed what they call sign. How do you say? I forgot what's the abbreviation, but newly developed intimal injury at the edge. Arch is difficult, and we still haven't had case-to-case how do you say, appropriate shape, and which I think a lot of difficult problems still exist.
Sure.
Taylor.
Yeah, in those particular cases, where there's a sharp angulation, where the aneurysm tends to push itself up into the left chest, and then there's a sharp angulation going down. Those are challenging, and I think in those particular cases, there's an argument for trying to do those open and trying to remodel the aorta if you can, because they're going to pose difficulty for endovascular stent grafting in terms of the angulation. So in those particular cases, I might be more inclined to do an open operation. It's also worth mentioning that in those cases where there's that sharp angulation, there's a lot of forward pressure on the arch, and then those are precisely the cases where the arch comes anteriorly, where it comes to the midline, or maybe even a little to the right. So the anatomy is bad, but the result of the anatomy is that there's pressure on the aorta pushing it towards the midline, which makes the open operation easier. And so you can maybe try and resect some of that area and pull it down, so you have a nicer angulation later on if stent grafting is needed distally, something like that.
Sure. Irbaz.
Yeah. So just taking off the results of the analysis, and from your general experience, how do you select your patients preoperatively, and based on your findings from this study, how do you think that is going to change? What will you do differently, or what would you suggest that aortic surgeons do in their practice in terms of preoperative testing, and what cutoff of kidney disease or GFR would you recommend?
This forecast article only dealt with isolated total arch replacement. So that is not be generalized for the all arch. For example, total arch, aortic arch aneurysm, degenerative aneurysm. In our data, about 30% of these patients having concomitant significant coronary artery disease. Also, aortic valve disease is pretty common also. So we have to measure the magnitude of operation compared to this elderly patient, the frailty. So this is important things. Then we have alternative approach like stent graft. But these multifactorial factor in terms of morphology, also lung function, pulmonary function. In terms of renal function, if simple isolated total arch present by our hand, let's say EGFR 40, we just simply go ahead. That is not the factor we stop the operation.
I see.
I'm sorry, I didn't say it well, but
no. What is what is in your experience? When do you recommend a CTA? I mean, I'm sure every patient gets a CTA for a CT scan, no, with a contrast. But in this patient with chronic kidney disease, how do you manage the contrast? Do you have a different protocol? Do you ask radiology to do a different type of scan with less contrast? Or do you just prep your patient? How do you do it? How do you investigate the aorta in this patient with chronic kidney disease?
Very good question. I didn't prepare the answer, but what I'm saying, as our paper said, we don't do this preoperative contrast enhanced CT maybe 2 days before operation. If patient have a very low creatinine level, high creatinine level, and we don't use any contrast enhanced CT. Plain CT, we can see the size, shape of the aneurysm. We usually skip extremely bad kidney.
Sure.
And I think John will agree with us. But
John, what do you think, Dr. Ikonomidis, what do you think about these patients and their pre-op evaluation? When do you recommend or when you do not recommend to do a CT scan? Do you ever use MRI? And what is the role of it in these patients with chronic kidney disease?
I must say I'm not a big fan of MRI scans to evaluate the aorta, but I will make an exception in patients with severe kidney disease. Sometimes, honestly, you can really get all the information you need from a non-contrast scan. Even the anatomy of the great vessels and everything else. And I have operated on patients without a contrast scan, just a regular old CT scan. And I can see everything that I really need to see, honestly. I'd prefer to have contrast. I think we all would. But, you really don't need it that much in a lot of cases. So, I have a similar approach in terms of following my patients with aortic disease. I'll get a contrast scan, and if it's a straightforward aneurysm, the next few scans might be non-con scans just to look at diameter. If you're just measuring diameter, you don't need a contrast scan for that. And then at some point in the future, repeat a contrast scan down the road, but something like that. So yeah, I think you can accomplish a lot with a non-contrast scan.
Yeah,
but Gianluca, I think at least if the patient over 40 or 50 years old, I think the incidence of coronary artery disease, even without chest pain, I think it's a limited amount of contrast media. Maybe used for coronary angiogram with very limited contrast media by our cardiologist.
Yeah,
John, you routinely do coronary assessment by catheter or a CTA, depending on kidney function?
Yeah, so that's another interesting one. You know, my approach there, I have, you know, my cardiologists, if I really need it, they'll do very limited dye angiograms.
Right.
But sometimes, honestly, especially in younger patients, by younger, I mean, you know, 40s, 50s, if the CT scan doesn't show significant calcification in the arteries, I might not do the coronary angiogram. I might just proceed without it.
I see.
Yeah.
Interesting. There is another element I've always been curious about is the post-op, actually, first the intra-op management of these patients, because when we say we go on bypass and we are full support, what is your index? At what index do you perfuse on bypass?
Oh yeah, that's a great question. You know, my approach has been, you know, I use a lot of selective antigrade through the Ikonomidis. So when it's time to circ arrest, I tell the perfusionist to drop the flow to 1 liter a minute. I put a clamp across the proximal Ikonomidis, and then I've got an art line in the right radial, and I tell them to increase the perfusion until the map is 60.
Oh.
And then at a map of 60, I have bilateral cerebral oximetry. And if the numbers are holding, we're good. If they're not holding, I'll tweak the map up, because, you know, a lot of these patients are hypertensive. So a map of 60, relatively speaking, is hypotensive for them. Yeah. But the problem is that with selective antigrade, if you're just perfusing through the Ikonomidis, you have a lot of back bleeding from the carotid and the subclave, which is fine. You know, a lot of times you can just drop a sucker down in there and clear it. But if you're in a position where you have to increase your flows to 2 liters a minute, you know, to keep the cerebral oximetry, then sometimes it's challenging to clear all that blood to do the operation, and I may then proceed with snaring those arteries, you know, to reduce flow to enable the operation to be done. But my general approach is map of 60, monitor cerebral oximetry, and, you know, don't plan to be there very long. So for a hemiarch, my average for a hemiarch, just a straightforward hemiarch, is going to be somewhere around 8 to 10 minutes. And for a full arch replacement, depending on the technical aspects of it, 30 to 35 minutes. So that's, you know, that's where under those circumstances, you have to be a little bit more judicious with the cerebral protection. And I may, as I said, introduce a second catheter into the carotid, or just snare those 2 arteries and operate that way. And the cerebral oximetry is the big thing for us.
Yes. We use that inverse monitor, which is cerebral oximetry. I think it's pretty much the same. I think in Japan we have a history, Kazui, Ueda, Okita. These are big
yeah, fantastic history. Yeah.
But we use 3 separate cannulation for the each arteries, which not only perfusing a whole 4 brain that's a vessel, also no back bleeding from the branches.
Yeah.
Which I think is very important. Just like off-pump surgery, you cut the coronary artery, you're breathing like this, you cannot make a good anastomosis, right, Gianluca?
I agree.
So I prefer to use the intracoronary shunt. But same token, I mean, the arch vessel, separated arch vessel, pretty much clean in a field. So deep, deepest area of distal stump, descending aorta or proximal arch, distal arch, to be clearly visible with a good exposure.
You can do the same thing with selective antigrade and just snare those.
Yeah,
that can be done.
Is it safe, Dr. Ikonomidis, to clamp? No, I clamp both of them. Generally, like I perfuse the Ikonomidis and I clamp the other 2.
Yeah, I think that's fine. The only caveat, of course, with these is if, for example, in the case that Dr. Asai showed, which gave me goosebumps actually, because I've been there. I've seen those horrible atherosclerotic aneurysms. They're terrible. Every time you touch something, a plaque falls off, and the whole time you're thinking the patient's going to have toe necrosis and liver necrosis and all this stuff from all of this embolic stuff. And that atherosclerosis tends to go into the proximal great vessels, and putting clamps on them without directly visualizing them. But it's the same for snares. It's always a little bit of a risk.
Yeah,
so
sure.
Probably the safest thing is what Dr. Asai does, which is to actually transect, look inside, gently place a cannula in, and initiate perfusion. I don't do it all that often because I find it just kind of clutters the operative field. I don't like all these tubes going all over the place. So I reserve that technique for specific instances where I think that it's going to be necessary, where the operation is going to be particularly involved. And I generally stick with a side graft in the innominate, which is completely out of the operative field. And it just makes the whole field very simple.
Sure. And then in the post-op, and this is a question for both of you, how do you manage it, the patients? What type of index do you generally keep in the ICU, these patients? What type of mean arterial pressure? Do you generally leave this patient a little bit more liberal with the blood pressure because of the kidney disease? You want them to perfuse, no? We say to perfuse better the kidneys, or do you apply a tight type of protocol? And what is your index? Do you have a Swan-Ganz in these patients, and do you follow Swan-Ganz index to manage your post-op, or Dr. Asai?
Yes, that's a good question. We use very similar post-operative medication to the other valvular heart disease and coronary artery disease. Once reconstruct everything, we just keep, for example, maybe 2 or 3 microgram per minute per square of dopamine, and we use hump carpeti. You may not have a hump. There's a ANP products is commercially available in Japan.
Oh.
Make a renal flow optimize, and it's good function to the dialysis. So it's a small dose we use. BNP products in the United States I have, but ANP products in Japan, which is very useful for the, I think, CKD patient, but not specifically for this total aortic arch patient. That's also used for other cardiac surgery patient. So in terms of medication, specific medication for total artery replacement post-operatively, probably no. We're making sure there's no bleeding from anastomosis or some dissecting area, which is most important. You have to finish with super dry.
Super dry, yeah.
Asahi super dry,
Yeah.
What do you do in your post-op, Dr. Ikonomidis?
Yeah, I try and stay away from vasoactive agents as much as possible. So run the indexes high and try and keep the blood pressure high. You really want to give the patient's organs what they need. And so I think a mistake that's commonly made is that we want everybody with a MAP of 60 to 70 post-op and a blood pressure of 120 on 80. That doesn't work in these patients. And this is why, again, another point by Dr. Asai, you have to be really hemostatic, because you have to plan in the post-operative period to run these patients hypertensive. You have to do it. You will
agree. Yes, important point. I don't use it often, but if you prefer to use frozen elephant trunk or some, spinal cord may not be really certain. Good mean arterial blood pressure and good perfusion, these kind of things are crucially important. These CSI is multifactorial. There are a lot of papers. We read a lot, but more you read, the more you are confused. So good things is complete hemostasis, keep a good mean blood pressure and good perfusion. May I write, John? I think this is very important.
Yeah. It all builds on itself. The success of operation in chronic renal disease, it starts with, low pump times. It starts with, not a lot of blood products, which can cause fusion reactions and thrombosis, and not using a ton of fresh frozen plasma, not having to use factor 7 or PCC, because those things, they all sort of set you up for problems post-operatively. So quick operation, good hemostasis, run the blood pressures high. The ante's higher in these patients. There's less room for error. And so you have to do everything very well to get these patients to come through without really insulting their kidneys.
But I would say for educational purpose, if you want finish quick operation at the beginning, you may not be successful always. If you want to finish the operation 4 hours, sometimes takes 6 hours, maybe 7 hours, depending on the complexity, or especially the deep area sticking the other tissue. Then I think cardiopulmonary bypass time is a very, very important factor, which we wrote in an article, which is related to the coagulopathy. Longer the pump time, you always have a more problem of hemostasis, always. Somebody said just hypothermia. Hypothermia always coming with a rewarming, cooling phase. So automatically that's a longer pump time would be a big problem. Also circulatory arrest, which means reperfusion may be the problem for some organ. So these are factors important to keep in mind. And I think it's a systemic inflammatory reaction to be avoided, and coagulopathy to be avoided. The best way to minimize the pump time, if you can.
Sure.
For that, most important thing, I really want to emphasize good exposure to create before you sewing. You don't go rush to just sewing. No, that's not good. Make perfect exposure, especially deep area of the distal stump, also left subclavian, perfectly. Then have your resident sew comfortably. That eventually makes this operation beautiful and short time. I mean, with short time. I think that's a way we should go as one of the armamentarium. We do have a lot of stent graft, but I think open aortic surgery is still important because atheromatous burden, thrombus, and these dangerous area, it's not perfect for the stent endovascular treatment, even with the latest products.
Yeah.
So this open surgery is still important, but with very organized way.
One question that I have for both of you, like when you open the distal arch and you're doing a total arch, let's say after a dissection, so the descending is dissected, and you perform what we call fenestration, the opening of the chronic dissected flap to allow your elephant trunk to perfuse both of the lumens to avoid to malperfuse those vessels that now chronically arise from the false lumen of the dissection. How do you decide the length of your fenestration, and how do you decide the length of your elephant trunk within it? I'm always worried that my elephant trunk is too long and selectively goes down into one of the vessels. And I'm always worried to make a big disaster by cutting the fenestration and somehow cutting the aorta and then have major bleeding from the distal aorta.
Sure. Yeah, so again, no more than 10 centimeters for the elephant trunk, and you can figure that out beforehand. where you designate. There are some prefab grafts, of course, that have a collar right where the elephant trunk's going to sit, and you can just trim it exactly where you want it, or you can invaginate it. You can make your own, which I often do.
Yeah.
The answer to the question about the septectomy that you're talking about, I refer to it as a septectomy more than a fenestration, but the idea is the same. I just go as far down as I can, that I can safely go down. And there's a particular set of scissors that we have called Jorgensen scissors that are they're like Mayo scissors, but they're very long and they have a little curve on the end of them, and you can dissect down a very long way. Usually, I don't spend a lot of time thinking about being worried. That I'm gonna perfuse one side or the other, because usually I can get a very generous removal of the septum, which I really think will go much longer than my elephant trunk. So yeah, it's a valid point, but I think my attitude towards that is just take as much as you can.
Take as much as you can.
Okay.
Dr. Asai, what do you do in arch with a dissection on the distal aorta?
I think I understand your question correctly, that you are talking about chronically dilated, especially the shoulder of the distal arch in a chronic dissection.
Correct.
Right? Okay.
Correct.
What I do is, let's say distal arch is 6 centimeters and coming down maybe 4 or 3 point. So we do total arch replacement, as I showed in the video, which was, I mean, same to that. Then I'm making, John said septectomy. I don't know how they call properly, but I use maybe U or V, how do you say, cutting in an intimal flap. That's same, John? Or you say that's septectomy? So we don't call that fenestration, Gianluca. Fenestration is, I think, it's a classical procedure to make some hole in a septum, and before the current procedure. So that's, I think it's a V cutting or U shape of U cutting, making double bar perfusion, to be sure, because that we cannot bring that intimal flap back to the pseudolumen, because size is so different. I mean, true lumen so much shrinked out, and false lumen is expanded, which is a big another problem of dissection in the chronic period.
Yeah.
In terms of elephant trunk is concerned, I don't use elephant trunk. I'm making sure just a very big bite, hemostatic bite to the double bar anastomosis, I think, which is adequate. And I think classic elephant trunk or even frozen elephant trunk have no role for this specific disease, in my opinion.
Okay.
I just had a case of arch aneurysm, which was after hemi-arch replacement in other facility.
Mm-hmm.
The patient had a huge double bar descending. Arch was 6.5 centimeter. Not only that, 3 supraortic branches all dissected, chronically dissected. Tough case.
Very tough case.
That also, there is some trick. Very short 2 centimeter or 1.5 centimeter of piece of branch connected to the double barrel fashion, 3 branches. Then introduce a selective cannula.
Oh, I see.
Patients went very well.
Yeah.
But what I'm saying is the double barrel portion, that's not appropriate for us to insert elephant trunk, because you can go either way. I mean, we should perfuse naturally as it was. You know what I'm saying?
Yeah. I think that the great point here is from Dr. Ikonomidis is to do a long septectomy of the chronic dissection. Sometimes I might admit maybe I'm too worried to go down blindly and don't see. So I'm a little bit skeptical when I'm there just to cut. I'm always cut less, you know. I always tell everybody I do long septectomy, but in my own real at the table side, I still cutting down in the descending aorta still give me goosebumps. Probably I'm just like, I should be a little bit more aggressive down there, so then you can land in your area. One more question, please. Tell me.
Yeah, may I just add one thing? I think the role of septectomy in this intimal flap is just avoiding the septum, just occluding one lumen or the other. You know what I'm saying? If you cut some this way, as perfusing both lumen properly, I don't think that the depth of septectomy really does matter.
Good.
That's my opinion.
We are almost eating the 1 hour for our talk, but I want to ask very quickly a quick question. Retrograde cerebral perfusion. I've been trained in Mount Sinai Hospital, and all of my arch surgery comes from Dr. Gabe Diluozo in the School of Randall Grip. And there are some funny jokes. He always told me, Dr. Gabe Diluozo always told me that retrograde cerebral perfusion is like treating your headache with a suppository. So that was what he was saying. On the other side, so I've always avoided to do it, or I've never done it. On the other side, recently, by reading paper, I've seen that through a major STS review of the data of arch surgery and dissection surgery, actually retrograde cerebral perfusion was associated with very good outcomes. So what is your feeling about retrograde cerebral perfusion? Do you use it? Do you never use it? Or when do you use it? In a very short comment, because we are almost at the end of our life. Dr. John, please, John Ikonomidis, please.
I don't use it. Done.
You don't use it?
I use it very specifically. If you have any suspicion when you do aortic cannulation, maybe a little bit debris to the initial perfusion, just in case, 5 minutes after circulatory arrest, perfusing retrograde, hopefully to wash out. But in terms of protection of the brain, I don't think not that much addition to the circulatory arrest.
I see.
I mean, selective. Okita have a good paper presented in WATS, I think about 10 years ago. I think selective is a main way to go, especially complicated operation.
You know, it's kind of like antegrade versus retrograde cardioplegia. Retrograde cardioplegia works okay, but it's not as good as giving cardioplegia directly down the coronary arteries. Yeah. So it's an option, but it's not the best option in my opinion. But then having said that, there are authors that use it routinely, and their results are terrific, and you can't argue with that. So.
Correct.
All right, so I think we're getting to the end of our live discussion. Just before ending, I would like to ask Dr. Ikonomidis and Dr. Asai for your concluding words. How would you sum up your practice, circling back to our topic for the day, which was arch replacement in chronic kidney disease? How do you, what are your recommendations as experts on this that aortic surgeons can implement in terms of their pre-op, intra-op, and post-op practices? We've discussed a lot of them, but if you can sum it up in a few words, what would you say?
I'll be very quick. Dr. Asai, this is a difficult population of patients, and the presence of chronic renal disease in the setting of the requirement for an arch replacement really ups the ante in terms of preoperative planning, operative precision, operative timing, and postoperative management. So very careful attention needs to be paid to every aspect of this to get these patients through well.
John is right. So short comment, difficult short, but I would say this total artery preps, if you do effectively we don't use any contrast media during procedure. So I think it's an effective operation, good preparation, and good management perioperatively. Really, I think the total artery replacement open surgery still have a role in this group of patients. Thank you.
Excellent. So thanks again to everybody. Thank you, Irbaz, for your summing up. Thank you, Dr. Ikonomidis, and thank you, Dr. Asai, for being here. I think that was a nice discussion. Again, we are here with Journal of Cardiac Surgery. This is our live talk with the authors. Each month we pick up a talk from a paper, and we just invite someone expert in the field to have a nice chat on our morning. Thank you again, and have a great night.
Thank you very much.
Bye. Thank you.
Thank you.